All right. So this is Dr. Mark Bozek, right? And he works at Ventura Optometric Vision Care. Dr. Bozek, how long have you been practicing optometry for?
Since 1980.
Okay.
So this makes my 37th, 38th year.
Perfect. So today we're going to be going over some questions regarding the disability of low vision. Dr. Bozek has been more than willing to answer our questions to help us learn about it. So, Dr. Bozek, one of our questions is that is low vision caused by disease, accident, or is it possible for people to be born with it?
All three.
Okay.
Definitely, there are a great correlation of patients who develop low vision because of infectious diseases. There's a number of patients who develop low vision because of injury or accident. There are patients who are born with certain types of congenital anomalies that result in low or very poor functioning visual abilities.
Okay. And is it possible that a person could have low vision only in one eye, or is it?
Certainly.
Okay. And
Certainly.
then both too?
Yes, because both eyes develop individually, and retina is the internal correlation. If you can zoom in on this picture here, when we look at the retinal relationship, optic nerve, anything that could damage the nerve, anything that could damage the retina, anything that was a malformation during developmental correlation can result in low vision and poor function. So one eye, both eyes, it could be in your brain, it could be in your eye, it could be just in your optic nerve.
Right. And what qualifies a person to be legally disabled with low vision?
When your best corrected acuity in one eye is no better than 2100 with correction, or both eyes, or your visual field, that which we see surrounding our eye, is less than 5 degrees, then you can have 20/20 vision, but if you don't have a very large visual field, sometimes described as tunnel vision, then you also can qualify for the term of legal blindness and visual disability.
And what test do you perform to be able to diagnose a person with low vision? Or is there multiple tests?
It depends on age. For infants, you're just looking at gross structure and viewing retinal pathology or a malformation of the eye. A lot of patients have what's called microphthalmia. That's a very small eye. It doesn't function normally, so that has limited visual capability. We have some patients who actually were born with one eye much smaller than the other, one microcystic and the other just microphthalmia. The microphthalmia eye has like 2400 acuity, best corrected. The other eye is light perception only, and sometimes no light perception.
What age group is the disability of low vision most common with? Or does it vary?
Low vision is most commonly associated with patients over the age of 80. Since the average age of onset for macular degeneration is 85, and macular degeneration is the primary cause of vision loss, to the degree that we would call this low vision or subnormal vision, these would be people with macular degeneration. And so I would say then the largest group would be over 80.
During your years of practice, roughly about how many children have you seen that suffered with low vision?
Early on, I used to see a lot because I used to volunteer at Easter Seals. I used to do a lot of work at Boswell, which was a school for the visually handicapped. I used to do Dean Triggs, and I used to do vision screenings for a lot of school system related low vision patients So I used to see a lot more. Now, some of those patients, of course, are 30 years older, and they've moved around. I don't see them very much anymore. I don't do a lot of those screenings anymore, so I don't see a lot of those patients.
When you did see those children, how did you help them get by in school being visually impaired? Were there any suggestions that you had for them in the classroom? For example, like magnifying glasses, or any tools that you recommended that they use to help them?
Absolutely. We use a lot of telescopic aids for children with low vision. There are many different varieties of, let's pause this for a second, and we're going to go over here to telescopic aids that are spectacle mounted. So you can interchange these by unscrewing them. You have handheld magnifying devices and telescopes, smaller ones that can be held in the palm of your hand, so they're very discreet. A lot of patients that are low vision don't want everybody else knowing they have a visual disability, so they would really like to not be as obvious as wearing a pair of glasses that look like this. However, if that's the only way that you can see, then that's what you're going to do.
Mm-hmm.
It just depends on quite a few variations, but the limited relationship of your vision is going to create that need. So these have different adjustments to slide the lenses farther apart or closer together. They are individually focusable so that you can adjust each eye separately for the magnification and proper viewing distance. Some of these instruments that you look at here can also have a cap on one side. Let's say one eye has a limited visual potential, but they can't see out of that eye, but it interferes with the good eye. You can take one of these scopes and you can mount it. Okay, so this is a little low vision aid, which is a magnifier for somebody who has an extremely poor visual relationship. The focal length of this particular aid is only a few millimeters, so somebody might look at this as a microscopic type aid. It looks a little funny, like Honey, I Shrunk the Kids, but you can look at this, and if you were to read something, you might have to be this close to see it. But I can see this very clearly, and it's magnified very nicely. So if you're looking at one eye,
Mm-hmm.
this is the kind of thing that somebody might use who, for a hobby, it might be something for reading, but you can well imagine how tedious reading would be if you had only one eye
Mm-hmm.
and you had to hold it this close.
Oh, yes.
Because you'd only be able to see about that much at a time, and so you would have to read very slowly. But compared to not being able to read at all, that's a miracle for
Mm-hmm.
some people. So there are a lot of different types of aids, and these are two eyes, different kinds of loops. Certainly people have seen jewelers have these kinds of things. That, a lot
Or
of
dentists.
doctors have them when they're operating.
Mm-hmm.
Oftentimes you'll see somebody like an endodontist, which would be doing root canals. They might have a very specific low vision device where you can see here there's a convergence angle in the lens. They're actually turned
Tilted.
inward
Mm-hmm.
so that you can get your convergence to your object of regard at a very short focal length, high magnification. So different types of low vision aids for different types of people, and these are all what would be considered spectacle mount or handheld. Now, some of these are really nice because what you can do is you can pull these out, and once you get them all the way out, you can unscrew them. It's a long screw. And then you can pop them in
To the
there,
loop.
screw it back onto the frame, and now you can have a long distance telescope as opposed to a microscope.
Oh, that's really cool.
Some of them actually have a characteristic uniqueness where you can focus it as a telescope, and then you can put on a cap which turns it into a microscope. So the same aid with an additional attachment could give you near vision and far vision.
Instead of having to switch back and forth.
Every one of these reduces your visual field. So this may give you the ability to watch TV, but you might only see a small face instead of the whole screen. So you're watching a big screen TV with something like this, it doesn't work too well. It might work okay if you're at a baseball game and you're trying to see a batter, or or you go to a concert and you want to see an individual person, just like we might if we took a pair of binoculars and we were looking at those to watch that stage. A person with low vision could do the same.
Okay. So for the next question, we have, what accommodations do you think teachers can make to help better the learning environment for a child who is visually impaired with low vision?
Certainly, most people with significant anomalies would require the help of a low vision specialist within the school system. We certainly have several really excellent ones here in the Ventura school system. I don't think I maybe should mention by name, but there are definitely some people that I can think of off the top of my head who would be very helpful. And they would do an assessment of that individual, which would include what type of magnification would be necessary in the books, what kind of lighting conditions would be necessary. If, in fact, they needed a low vision aid, under which conditions would that low vision aid be used, and then the teacher would be informed what needs to be done so that that particular student has the best opportunity.
So with that process, you do the child's exam and you determine that they need the aid, and
then oftentimes what I have done in the past is contact her
aid,
and she would then do her assessment. We would inform her what we're going to be using, and then she would best determine how that would be used in the school environment. I don't go on site and help because they have that low vision specialist opportunity within the school system that maximizes that student's opportunity. Plus, identifying that to the school through the low vision specialist is absolutely the best opportunity for that child to have continuity throughout their educational process. And typically, that person would follow them all the way through school. So, and then even at Ventura College, we have the opportunity for a low vision resource group, and they have their own related situations in terms of what they can check out to students, what they have as an opportunity. Sometimes students need to have their own low vision devices, and sometimes it's better if they do, but different economic relationships and different insurance carriers might limit what a person can actually get, how much is available to them, and at what is their copay. Some of these low vision devices can cost literally thousands of dollars. We have an interesting situation. I'll just grab it off camera and just bring it in. This situation right here with these glasses that have, it's not really a frame that's really, ornate or unique, but the adaptability of this frame for this device, if you can get a picture of this, you'll see that these lenses have little lines in them. Those lines are lenses that add together to give you a sum total without going to a really thick lens. And this is a high-powered lens. Of this particular one is a what's called a 6D. So this lens has a magnification capacity of 1.5x. And so you could wear these, and something as simple as this might give a person a chance, like I can see this here, but if my vision were worse than that, I might be here or I might be a little farther out in terms of focal length. But these kinds of lenses, we have all different kinds of powers. Some of them, both eyes. Some of them only have one eye. The other eye is blank. It just has a lens holder in there to, give it some appearance and balance, but it doesn't have function. So if you're right-eyed, you only use the right correction. If you're left-eyed, you use the left correction. If you're both, you use both. However, in the really high powers, the problem is the focal length is so short, you have to really work hard to get your eyes to converge in, and sometimes the power that's required is so high that a person can still only use one eye because they just can't converge that much. So we have to choose the dominant eye or the better functioning eye and then correct that. Low vision patients are generally so happy whatever you can do for them that they don't complain about little things like that.
Mm-hmm.
People that are older that have had vision and lose vision, they have expectations much greater than children. Children that lose their vision, they're just always grateful for whatever they get. They never complain about anything. Most of them that I've had that have the worst vision conditions, you wouldn't even know that they were visually handicapped. They wouldn't even let you know. As a matter of fact, I have one patient in particular who's a low vision resource specialist at Oxnard College actually wanted me to write a very specific letter indicating what her visual anomaly was because he didn't believe her because she did not limit herself.
Oh, that's cool.
Yeah, very much so. I mean, I was so proud of her and always have been that she does that. And, you know, I mean, it's really interesting. Visual disabilities certainly can limit people, but there are certain people that want to overcome their visual limitations.
They don't want to let it hold them back.
Yeah. We have grad students right now who have low vision, had brain tumor removed at 8 years old, now in a master's program at Channel Islands. We have several in the Oxnard College related situation, and a few in Ventura College as well. So they work very, very hard. They never limit themselves, and it's interesting to imagine being able to read only 3 words at a time, and have to read the same volume that every other student in the class has to read, and they never complain about it.
So if their vision is failing them, do other senses become more keener? Do they?
You know, I wish I could answer that question really well, because not having the visual handicap, I don't know. I would imagine that maybe to some degree the answer is yes, but I think they just work harder. I think that the ones that I know that are successful, they just work really hard, and they don't ever say no, and they don't ever pull up shy. They just keep going till they're done.
So a person that's losing their vision from the low vision or macular degeneration, if they're older, is there any possibility of them ever being able to see 100% again, like by surgery or anything like that?
Not at this time. Most of those patients, I mean, we have patients that can go to like 20/80. Remember, we were talking about 2200 or worse, best possible corrected view. And so if we look up at the chart, that's 2200, but you're only 8 feet from it. So you got to get another 12 feet back to see what that would look like at 20 feet. And then to assume that that's the best that you could see, how would you deal with the world? Very, very unique. I think that patients who have that kind of limitation, I'm sure that they become a lot more careful. They think about their surroundings. They think before they move. They don't just move. You don't see them tripping. As I said, a lot of them, you can't even tell they have a disability because they don't want you to know it. They work at that. So that's an interesting perspective. Personally, I can't imagine how hard that would be. I see it. I've worked with it. I've tried to do my best to help the people that have that situation, but I've never walked a mile in those shoes, and I don't know what that's like.
Okay. Well, that's all of my questions. Do you have anything else that you would like to add?
No, I think just simply to say that I hope that everybody out there has gained a little bit more of a perspective of people who have limited visual capability, and that they have a little bit more care in their heart for people who have these kinds of problems, and to realize that these are not the people that we can rush up to try to help. They don't want to be helped. They want to do it on their own. They want to be successful on their own. That's why they choose whatever low vision a device that they can maximize their living experience through, they're going to grab that opportunity, but they're not going to ask you to do it for them.
Awesome. Well, thank you very much, Dr. Bozek. I appreciate it.